Hi, my name is Sarah Madden, and I'm an occupational therapy doctoral student, and I wanted to welcome you to Hello. Um, do we need an interpreter today? It's real-world training and education to prepare therapists and therapy students to work with diverse linguistic populations. I'm an occupational therapist who graduated from Boston University in 1997. I have over 25 years of experience in every field of rehabilitation, and I will say most everything except pediatrics. I became a certified hand therapist in 2006 and have worked in various outpatient departments since then. Currently, I work for Spaulding Rehabilitation and I work in the cities of Lynn and Peabody, Massachusetts. I work with a wide range of diagnoses and a diverse group of people from various cultures and languages. I became passionate about improving communication with my non-English speaking patients due to my frustration at my inability to develop rapport with them like I usually do with my English speaking patients. Things were lost in translation, my attempts at jokes and things like that, and my casual chit chat. Something was missing, but what and why? When I started pursuing my doctorate, I chose this as my project. I wanted to improve the experience of both the therapist and the patient when there's a language discordance. With education and experience, we can bridge this gap in communication, and instead of just hearing our patients, we can truly listen to them. As therapists, we often ask our clients questions and hear their responses, but authentic listening goes far beyond that. To listen is to be fully present and to engage actively with what is being said, to seek understanding beyond those surface level words, and to respond with empathy and intention. This becomes even more critical when working with patients who do not speak English. Too often I've witnessed how language barriers become listening barriers, despite the presence of interpreters and translation tools. To truly listen means understanding the patient's story and their context, validating their experience, and recognizing the depth of what may not be directly spoken. It is both a professional and ethical obligation to approach every interaction with humility and curiosity required to bridge those gaps. With an increasing immigrant population, the number of individuals who speak a language other than English has also increased. 26 million individuals are deemed to have limited English proficiency, and despite federal and local laws in place, many inadequate interpreter services are still available for these patients. Not speaking English proficiently or a language other than English is a primary barrier when receiving adequate healthcare, I should say. Limited English proficiency is defined as individuals who do not speak English as their primary language and have limited ability to read, talk, write, or understand English. So first, I'd like to address some of the laws that have been established to ensure improved communication to our patients who do not speak English. The first one being the Civil Rights Act of 1964, specifically Title VI. And under Title VI, any organization, program, or activity receiving federal financial assistance is required to take meaningful steps towards providing language access, which includes a mixture of two essential language services, oral interpretation and written translation. There's Executive Order 13166, which was signed by President Bill Clinton in 2000, and it requires federal agencies and recipients of federal funding to improve access to services for individuals with limited English proficiency. The Affordable Care Act ensures that all recipients of federal funding have access to language services free of charge in at least 15 common languages. Language access plans are documents that each healthcare organization has that will provide services to individuals with limited English proficiency, ensuring meaningful access to their programs and activities. These plans are crucial for your organization, particularly when they're receiving federal funding and are subject to Executive Order 13166. They are actually required to have language access plans. And lastly, I'd like to mention the SPEAK Act of 2024. This is something that has been fluid and changes with each presidency. The bill requires Department of Health and Human Services to issue guidance with best practices for improving telehealth services for non-English speakers, including with respect to using interpreters, providing accessible instructions, and enabling multi-person video calls. Despite these powerful acts that the government has tried to ensure, many patients do not know their rights and are often apologetic when they request an interpreter. Our role as healthcare professionals is to remove any stigma from using interpreters and to utilize these services with ease and proficiency. I often know when I take my patient in from the waiting room that they do not speak English. So I usually try to break the ice initially. I say hello, but I also say, do we need an interpreter today? Hence the title of my lecture. Effective medical interpreting ensures that patients can fully understand their diagnosis, treatment options, and medical instructions while helping healthcare providers to gather accurate information about a patient's symptoms and medical history. This field is key to ensure health equity and reduce disparities in healthcare access and outcomes. So here's some little advice when you're using interpreters. Unfortunately, most of us use interpreters and have never been properly instructed in how to actually communicate via an interpreter. So when you're using an interpreter, it's important to say only a few sentences at a time, and this gives the interpreter time to relay your words. This can be very disrupting when you're into your flow of thoughts, but you'll eventually get used to it. I tend to talk a lot, and I had to hold myself back quite often when I use an interpreter. Um, Thinking out loud is a big no-no because interpreters are taught to translate everything you say. So I often have to tell the interpreter, oh, don't translate that. I was just thinking out loud. And I do tend to talk to myself a lot, unfortunately. Keep terminology simple, as a lot of medical terminology is unable to be translated. Also be selective of your descriptors, as they often don't translate well. This also is very important when I find when asking a patient about pain, and it can make a difference between whether you're talking about joint pain or nerve pain. If you listen very carefully to a patient's descriptors, it's very helpful. The teach back method is when you ask the patient to relay the information back to you. At this time, you can clarify any misunderstanding. This goes with English speaking patients, non-English speaking patients, but patients tend to nod a lot and say yes, 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 yes. So with any patient you're treating, you want them to say, what is your home exercise program? Show me what you're supposed to do at home. It's very helpful. For home exercise programs, protocols, precautions, it's great to have handouts in common languages. I have most of my handouts and a lot of educational tools in Spanish. I don't have many in any other language. But what I do is while I have the interpreter, I educate the patient on their diagnoses, the anatomy of what's going on, and I go through their home exercise program while they have the interpreter there, and then I do the teach back method with them. It's also important to document in your medical record that you used an interpreter. I put their names and ID number into my treatment session. The system I use, Epic, actually has a section that you're supposed to officially put that you used an interpreter. You have to document whether a patient declined an interpreter, which often happens. They think they speak English enough and they don't want an interpreter. And then also if they use a family member, an ad hoc interpreter is what we call someone that's not medically trained. I often have, a lot of times my patients feel more comfortable having a family member translate for them, and that is fine. I think officially you're not supposed to do that, but I try to go by what is comfortable for the patient. On particular busy days, there's times when I haven't had a chance to look ahead at my schedule and I discover my 2 o'clock evaluation doesn't speak English, and this can significantly complicate my already hectic day. The extra steps involved, which is locating an interpreter, ensuring a quiet space, and maintaining a reliable connection, can quickly add stress and delay. For example, I may bring my patient back only to find that all the private rooms are occupied. I then go to retrieve an iPad for interpreter services, and fortunately, there's one available. But when I return and begin introducing myself to the patient and using the interpreter, my connection drops, which often happens in my clinics. Get another interpreter, start the process again. But this time, the interpreter is struggling to hear both me and my patient because of the background noise from the other therapists in the clinic. During the session, I discover the patient is unaware of why they had surgery or why they need to wear their splint, which is extremely important to protect the surgery. I then, via the interpreter, use anatomical models to improve understanding and go about addressing all the necessary precautions. However, I noticed that on a few occasions, the interpreter does not relay what I'm saying. So to confirm the patient's understanding, I ask them to repeat back their precautions. We just talked about the teach back method, and it's an essential step for ensuring safety and proper healing. These kinds of barriers directly impact patient care satisfaction and ultimately functional outcomes. Despite having 28 years of experience as a therapist, and I've worked in many clinics with a lot of patients that don't speak English, I continue to struggle with the logistics of using an interpreter effectively. It's a reminder that even the most experienced providers face limitations, and the tools often fall short. So I'd like you to take a few minutes to reflect. I have a few questions that you can look at. You could write this down, or you could just think about it, and then we can talk about it after. Can you ever recall a time when you felt that someone wasn't listening to you, and what emotions did that bring up, particularly in the healthcare field? Like you have a doctor, you keep telling him something's wrong and they don't listen to you. Um, how did that experience affect your ability to express yourself to get what you needed? Have you ever been in a situation where you didn't speak the dominant language? Were you on vacation in Spain and you injured yourself and had to go to the hospital? What was that like? Can you recall how scary it was to be in a healthcare system and you couldn't speak the language and didn't understand what the doctors were telling you? Um, how can these experiences inform the way you communicate with patients who have limited English proficiency? And what strategies can you use to make sure every patient, regardless of language, feels heard and respected in your care? Um, I'd also like you to take a moment to think about how complicated our healthcare system is and how frustrating it is if you do speak English to even navigate the system that's written in your language, the doctors speak your language. So put yourself in the shoes of a patient that either does not speak English or speaks it, but not proficiently. They understand basic commands and words, but it's very difficult for them to navigate this complicated healthcare system. I think that helps us be more empathetic to our patients. And I think we're all guilty of it when we take a patient back. And I've seen my fellow therapists do it. And I think I'm much more aware now that I'm doing this project, but they're like, oh, they roll their eyes and they sigh. And it's just, and patients can read that off of you. If you're kind of frustrated that you have to use an interpreter, I've kind of taken it on as my challenge to like, just, all right, we need an interpreter, let's go. And, try to not let it affect the way you communicate with your patient. We'll talk more about all of this, but thank you for my introduction. Thank you for listening to my introduction to Do We Need an Interpreter today? Thank you very much and have a nice day.